a media relations specialist with SSM Health. Today we're going to be talking about preventing sports-related injuries and playing at the top of your game. Our guest speaker today is Dr. Christopher Kim with SSM Health St. Mary's Hospital and SLUCare Physician Group. Dr. Kim is an orthopedic surgeon who specializes in sports medicine and arthroscopic surgery of the shoulder, knee, and ankle. Today he'll be focusing on how to prevent sports-related injuries and how injuries can impact future performance and recovery from past injuries. If anyone has any questions throughout the presentation, feel free to submit them into the comment feed and we will try to answer everyone's questions. Dr. Kim?
Thanks very much, Steph, for the introduction, and thank you guys for listening in over your lunch hour. I was asked to do this talk a couple of months ago, and I thought it'd be a very interesting and fun way to talk about sports medicine. So again, thanks a lot for listening in. I thought I might start off with a brief introduction of myself a little bit more, just so you know who you're talking to, and I don't seem too much like a stranger talking to you today. Again, my name is Christopher Kim. I was born in the United States, but we moved to Canada when I was quite young, so I grew up in Canada. So my college I did at McGill University in Montreal, where I majored in physiology and religious studies. After that, I went to Winnipeg, where my parents and family are, and I did my medical school training and orthopedic residency training at the University of Manitoba. I was one of those students that knew they wanted to do sports medicine pretty early on, so I got involved in orthopedic sports medicine very early. One of my mentors, Dr. Peter McDonald in Winnipeg, a very well-known sports medicine surgeon. He's the team physician for our NHL team in Winnipeg, the Winnipeg Jets. So I helped out with Jets coverage whenever I could. And I usually ask people if they know who this bottom team is here, this football team on the bottom left here. But in Canada, we have the CFL, and the Winnipeg CFL team is the Winnipeg Blue Bombers. So again, Dr. McDonald is a team physician, so I helped out with coverage for our CFL team as well. And then after I finished my residency training in Winnipeg, I finally came down south. I just completed a sports medicine and shoulder surgery fellowship at Duke University. And of course, as a sports medicine fellow, we're very heavily involved with sports coverage as well down at Duke. So I just completed that last year, and my career brought me here to St. Louis, and I just joined the faculty here at St. Louis University. And I went from being a Blue Devil to a Billiken. So now I'm one of the sports medicine orthopedic surgeons at St. Louis University, and as part of my job description, I'm team physician to the Billikens and help take care of our athletic teams there too. I am part of a very good sports medicine team at SLU. Dr. Scott Carr is my partner, orthopedic surgeon, more senior than I am, of course. And we're the two orthopedic surgeons. We also have two primary care sports medicine physicians, Dr. Willie Mitchell and Dr. Mina Hong, who are also very good. And our sports medicine PA is Lauren Smith, who also just joined us recently from Chicago. Duncan still hasn't given me a picture of himself, but Duncan, that's pretty much how he looks. And my clinical nurse, Julia Santiago. Duncan really works with Dr. Carr, and Julia works with me. And they're very much involved with our practice as well. So when I was asked to do the talk, I was kind of given an idea of the demographics and the kind of people who might be listening. So I really tried to hit on some points that might be of interest to you. I thought what we would talk about is, number one, performing at the top of your game, and then perhaps touch on some common injuries in sports medicine, things that we deal with, in case you have some questions about that. And then we can talk briefly about return to sports and high-level activities after injuries. So a couple of months ago, we actually put out an article at St. Mary's entitled From Couch Potato to Weekend Warrior. And that was really speaking to how to kind of get back into sports and high-level activities. And really what it speaks to is how do you prevent injuries while trying to optimize your performance in your activities. So I thought I might spend a few minutes just talking about those points that we mentioned in that article. Not all of them. The first point was, the first tip that we mentioned in that article was don't jump into your end goal. So if your goal is to be Usain Bolt, you can't expect that to happen in a month or two. It's very reasonable to have a regimen or a proper idea of how you might work your way up to that level. So if your goal is to run 20 miles in a week, for example, maybe it's a good idea to start off with 2 miles and 3 miles and then 5 miles and then work your way up to your goal. And don't be too disappointed if you're not running like Usain Bolt after a week. So that was the first point. Make yourself very reasonable end goal and work your way up to it. The second point I want to mention, this is actually a pretty important one, is warm up to warming up, meaning it's very important to incorporate a good warm-up to your workouts. You'll notice on TV when you see professional athletes, they're always on the court or the field warming up a good half hour, a lot of times more, well before their actual game. They get their body warm, their heart rate up, they make sure their joints are loose so their ligaments and tendons are nicely stretched, and that all helps them optimize their game, but also to prevent injuries while they're performing. So warming up is very important. As we become weekend warriors, we try to save time, and sometimes we don't have as much time, and so it's very common to not really warm up and really jump into your run or basketball game and whatnot, and those are the situations where you might get into some accidents and have some injuries. So remember to incorporate a warm-up to your workouts. The third point I wanted to mention was to plan rest days and to plan for recovery. Recovering after a workout should be part of your training regimen. If you watch TV, you'll see lots of ads about recovering and having rest after your workouts. You'll see ads from Nike, for example, or Gatorade, where they have special compression clothes that help you recover, or special drinks that help you recover. And of course, I'm not telling you to go out and spend money on these things, but professional athletes do consider recovery from their exercise as a very important part of their training, and that should be a good part of your training as well. From a physician standpoint, what we do end up seeing when you don't have proper rest days are things like these two pictures at the bottom, which are stress fractures. And these happen when you don't plan proper rest days and when your bones don't really get a chance to heal and to recover from whatever you're putting them through. The bottom right picture is a picture of a stress fracture of the tibia of the lower leg, which is a very common location for stress fractures. And then the picture on the bottom left here is a stress fracture of your hip, which is also very serious. And these things happen, and I do see them very often in our Division I athletes because they all have very strenuous training regimens, and they don't necessarily get a good chance to rest. Proper nutrition is very important as part of your training as well. It's your fuel for training. Whether it's a nutritionist or a trainer, you do want to get a good nutritional background to make sure you're getting what your body needs. Again, from a physician's standpoint, poor nutrition also contributes to these same types of injuries such as stress fractures. And in fact, when our Division I athletes get stress fractures or stress reactions, one of the first things I do is actually check their vitamin D, calcium, and iron levels to make sure those are optimized. So proper nutrition is very important as part of your training. The no pain, no gain mentality is something to be careful about. Certainly it's very important to work hard to accomplish what you want to do. But at the same time, playing or training through pain can also be a bad thing and lead to injuries that actually set you back significantly. For example, the picture on the right is supposed to be a picture of Achilles tendonitis. That could happen with too much work. And having Achilles tendonitis flare up and not go away can really set you back several weeks, even several months. So playing through that can be a bad thing for you. The picture on the left is a very common picture of a Little League pitcher. And one of the golden rules when it comes to pitchers for us is if you have fatigue in your arm or if you have any pain in your arm, is that you stop throwing and you get it checked out right away. So playing through a painful shoulder or elbow, especially if you're a pitcher, you want to be careful about that. So take the no pain and no gain mentality with a grain of salt. that was pretty much it in terms of what I wanted to discuss about optimizing your performance and perhaps preventing injuries. Again, don't jump into your end goal. Have a reasonable training regimen in mind. Remember to warm up, incorporate some rest days and recovery. Make sure your nutrition is optimal, and also be careful about the no pain, no gain mentality. I thought I might speak about some common sports injuries that we as orthopedic surgeons deal with. Of course, there's a lot, and this slide isn't meant for you to read every individual line, but we deal with all sorts of injuries, whether it's the young athlete or the elderly patient. Lots of injuries in the shoulder, such as shoulder dislocations, rotator cuff tears, arthritis, and fractures. Dr. Carr and I both take upper extremity trauma calls, so we deal with complex fractures of the shoulder. Dr. Carr does hip arthroscopy to deal with labral tears and femoroacetabular impingement. And we both do a lot of work in the knee as well, whether that's cartilage lesions, meniscal tears, or ligament injuries. I thought I might touch on a few. These three: rotator cuff tears, meniscus tears, and knee cartilage injuries. I was told about the type of demographic, the type of people that might be listening in, so I thought these three topics might hit on some points and perhaps pique your interest. And of course, there's a question period at the end, and I'd be happy to answer questions about anything else as well. So what is the rotator cuff? The rotator cuffs are a group of four muscles around the shoulder. There's the subscapularis up front, there's the supraspinatus up top, the infraspinatus, and the teres minor. These four muscles, the rotator cuffs, essentially help your shoulder rotate to do these kinds of motions and this kind of motion. When they do tear, it kind of looks like this. Sometimes they tear in younger patients from a traumatic injury, in which case almost always we end up operating on them. And sometimes they tear from more of a degenerative cause, and that's usually in the older patient in their 50s or 60s. And those are usually the types of rotator cuff patients that we see in clinic. How do we treat rotator cuff tears? Simply speaking, there's really only two ways. Either it's conservative treatments without surgery or with surgery. If it's conservative treatments, really the mainstay of treatment is physical therapy to try to strengthen whatever you have left. Or we also do injections into the joint to help with your pain and motion. The surgery aspect of it, nowadays most orthopedic surgeons fix rotator cuff tears arthroscopically. That's minimally invasively through small incisions around the shoulder with a camera. But there's also a good number of surgeons who still make an incision to fix rotator cuffs, and that's absolutely not wrong as well, and the results are exactly the same. And in fact, a very well-known orthopedic surgeon that I trained with at Duke still does all of her rotator cuff tears with a mini open incision, and they all do very, very, very well. You may know lots of people with rotator cuff tears, or maybe even you have a rotator cuff tear, and you may notice that depending on the tear, or the patient, or the person you know, the treatments are always different. Maybe one person is doing physical therapy, maybe one person was told to do surgery, and that may be confusing to you. And the reason that is because it's not always clear who should get surgery or what kind of tear should get surgery. And I thought I might throw out some interesting points. A rotator cuff tear isn't always symptomatic, meaning you could have a rotator cuff tear and have no pain and full motion and full strength and do just fine. And in fact, there are some very good studies out of Washington University, in fact, that show that if you're over the age of 60, there's a good number of people, about 30–35%, maybe even more, some studies say, that have rotator cuff tears and they don't even know it because they're doing just fine. So that's the first point. Just because you have a rotator cuff tear doesn't mean you need surgery, and you might end up doing just fine. The second point is many people with rotator cuff tears, if they have pain or weakness, they actually end up doing quite well with physical therapy. Some studies will say that up to 85% of people recover, do better with their pain, get full range of motion, and get all their pain back with physical therapy. And so again, just because you have a rotator cuff tear doesn't mean you need surgery, and there's a very good chance that you'll get better from physical therapy. So that's the other point. The caveat to that is that if you do have a full rotator cuff tear, there actually is a chance of the tear getting bigger. And if the tear does get bigger, there's actually a pretty decent chance of that tear starting to become more painful as well. It presents a little bit of a conundrum whether we send a patient for physical therapy and non-surgical treatment because we know that they're going to do well, or whether we decide to do surgery on them because we know the tear might get larger and eventually become painful. So that's why different surgeons, depending on the patient, the age of the patient, the hand dominance, whether the tear is new or old, lots of different factors go into play whether we decide on to do surgery or not surgery. There are some slam dunks, of course, with rotator cuff tears. For example, if you try conservative treatments such as physical therapy and injections and that's not working, then surgery, of course, is very reasonable. In younger patients, we do consider fixing rotator cuff tears as opposed to conservative treatments the younger you are. And of course, traumatic tears, if it happened from a fall and is very new and very fresh, the chances of it healing with surgery is much better, so we do often lead towards fixing traumatic rotator cuff tears. This is kind of what it looks like when we fix rotator cuff. Again, many surgeons nowadays will do this arthroscopically with a camera and small incisions around the shoulder. There's a lot of different ways we fix them. Generally speaking, we use what we call these suture anchors, where we put anchors into the bone and they have sutures coming out of them, and then we tie the tendon back down to the bone using different kinds of constructs. Returning to play or returning to activities after a rotator cuff tear, well, you can think of it simply as an early phase and a late phase. The early phase is really when we're waiting for the rotator cuff tendon to heal back down to the bone. That could take anywhere between 3 and 4 months, and some studies actually think that it actually takes longer than that. So for the first 3 or 4 months, we're actually protecting the shoulder quite a bit to try to make sure the tendon has a chance to heal back down to the bone. And then after that, after about the 3 or 4 month mark, when we think the tendon is fairly healed, we start strengthening and more aggressive activities, and that's usually the late phase of rotator cuff surgery rehab. Okay, I wanted to switch gears to the knee. Lots of different things we can talk about in the knee, of course, but what I thought we might talk about is the knee menisci. We have 2 menisci in the knee, one medial, one lateral. Those are these C-shaped structures. And this is a picture of the knee looking from the top down. Looking from the front, you can see there's a lateral meniscus here and a medial meniscus there. The menisci have various functions. One of the functions that people are most familiar with is that they're the shock absorbers of our knee. Every time we walk, they absorb shock. And they have some other functions as well, such as proprioception, stability in the knee, and so on. Menisci can tear, of course, whether that's from an accident and a traumatic injury, or they can tear over time due to degenerations and as our knees get older. There's different kinds of meniscal tear patterns. There's a vertical longitudinal tear. This middle one is more of a degenerative tear where things are more frayed. And there's something called the radial tear, which is kind of cut horizontally. There's all types of different patterns that that meniscal tears, menisci tear in. We treat them 2 ways, of course, with or without surgery. And again, depending on the type of tear, the patient, and so on, we choose one or the other. Meniscal tears don't always need surgery, of course. Non-surgical treatments are very, very common. Those really involve rest, ice, and anti-inflammatories to decrease your inflammation and the swelling and the pain. We do inject steroids and other things into the knee to try to help settle pain. Physical therapy does help with meniscal tears, and many people will get better with physical therapy. If we do end up operating on meniscal tears, we could either debride it, meaning remove part of the meniscus, or we can repair the meniscus, and there's different reasons why we do each. When we do debride or do a partial meniscectomy, this is kind of what it looks like. Depending on what the tear looks like, we try to shave it down so that we can have stable borders and then it doesn't cause you pain anymore. If we do decide to repair it, there's different ways of doing it, but simply put, it's repaired with sutures, and it's a little bit of a different rehab, as you can imagine, because now we have to wait for the meniscal tear to heal after we repair it. So it's a bit of a longer rehab. And depending on the type of tear, we make a decision of whether to repair it or meniscectomize it. Within the knee, of course, we can get cartilage injuries. Cartilage is a very smooth structure. When you have two cartilage surfaces rubbing over each other, it's smoother, apparently, than two blocks of ice rubbing over each other. So it's a very smooth structure. We have them in all our joints. They're very important. Unfortunately, cartilage, once it's gone, it doesn't regrow. So when you do have a cartilage injury, we do whatever we can to try to restore what we think is as normal of cartilage as possible, or try to take some pressure off of it so you don't have as much pain. When we talk about cartilage injuries, we can think of more of a focal cartilage injury, such as the picture on the top where you have one area, either due to an injury or a car accident or a sports injury or whatnot, where you have one area of the cartilage that you lose. Or the bottom picture here, as we put more miles through our knee, you can get general degenerative changes in the knee, where you sort of have generalized cartilage loss all throughout the knee. These are two different animals, and we do treat them a little differently. Just so you know, there's a lot of different things we can do with cartilage loss. One of the options is just going in with a camera and shaving and debriding it. When you have a focal cartilage injury such as like this, sometimes people shave the borders of it so it's nice and smooth again, so that that defect doesn't get bigger over time. Another option that we do is we actually drill into the bone underneath the cartilage. The idea being that it would stimulate some healing and some bleeding, and hopefully contribute to some healing and maybe formation of what we call fibrocartilage. That's what microfracture is. You may hear on TV of a lot of athletes getting microfracture surgery on their knees. And essentially what that is again, when you have loss of cartilage and you have bone underneath, what we basically do is we kind of punch holes into the subchondral bone under the cartilage. And the idea is that by punching these holes, they start to bleed, they introduce some nice healing cells into the defect. And what we know is that the defect eventually fills in with what we call fibrocartilage, which is not quite real cartilage, but we hope that it's a good substitute. Sometimes defects are too big for microfracture surgery. So in many situations, what we do is something called an osteochondral transfer. What that basically means is taking cartilage from another area that doesn't bear weight and transferring that cartilage into the area that does bear weight and cause you pain. We could either take cartilage from your own body, which is called an autograft, and every now and then it's too big and we need an allograft, which is a cadaver knee, where we take cartilage and bone from that knee and transfer that exact same match into your own cartilage defect. So that's called an osteochondral transfer. We also do procedures called autologous chondrocyte implantation, which is an interesting idea. Basically what it means is we take some of your own cartilage from an arthroscopic surgery, we send it to a lab, that lab grows that cartilage, so it's your own cells, so you have more cartilage cells, and then at a later date in a second surgery, we open up the knee and we implant those cartilage cells into the defect. And the hope is you regrow your own cartilage. That's called autologous chondrocyte implantation. It has fairly good results, and both Dr. Carr and I do that as well. If you have a larger cartilage lesion, but it's localized to one compartment, such as the left side or the right side, and it's still too big for all those other procedures we talked about, sometimes we do what we call a high tibial osteotomy. That's where we cut your tibia, realign the lower extremity, so that now the weight is going through a different area of your bone, as opposed to the area that causes pain. This is also a very common procedure with very good results. The other option is what we call a unicompartmental knee replacement. Instead of a full replacement, we just replace the compartment that's causing you pain. And that has fairly good results as well. If you do have too much cartilage loss in multiple compartments in multiple areas, of course the end game is a total knee replacement, where you just replace the entire joint altogether. And again, it has very good results. We don't like to do this in patients who are too young, of course, because it is a mechanical device. It does wear out. It does have a lifetime limit. And so Usually we like to do them in patients who are 60 and above, and we do push it to patients who are younger than that as well when they need it. The question of return to play is a very hot topic in any discussion group. When do you return to play or activities after whatever injury you may have? Of course, it depends on how bad you're injured. It depends on whether you had surgery or not. And even when you have the same surgery, return to play can vary among patients. It could even vary among the surgeon who did the surgery, depending on how they feel or when you're ready to return back to sports. At the end of the day, there's two ways that people decide on when you're ready to return back to play. There's a timeline-based criteria, and there's a criteria-based criteria. Of course, whenever anyone has an injury or surgery, one of the top questions is when can they return back to play? How many weeks, how many months, how many years? And it's a very reasonable question because you want to know, when can you return back to soccer, for example? A timeline-based approach is very important. It does give you an idea of the status of your healing and how your patient is doing, but ultimately, the best way to know is a criteria-based guideline, meaning as the patient is going through rehabilitation, you want to make sure they reach certain milestones to progress to the next stage of rehabilitation, and eventually they'll get to a point where they're ready to be released for play. Depending on your surgery, but depending on your injury, it varies. And we could talk about that if anybody has questions about specific injuries and return to play. Ultimately, the return to play decision has to be a joint decision between the surgeon or the physician, the physical therapist, and the patient. And the patient is very important as well, because at the end of the day, after an injury, it takes a little bit of time for the patient to get their confidence back and to get their muscle memory back and returning back to sports. So they need to have the confidence to return back as well. So for my patient, the decision to return to play is a discussion between the therapist and the patient. Well, that's all I have for you. Thank you very much for listening in. Again, we have a very good sports medicine team at SLU. Dr. Carr and I are the orthopedic surgeons. We deal with pretty much anything in the shoulder, elbow, knee, or ankle, and we're happy to answer any questions or see patients in clinic. Dr. Mitchell and Dr. Hong are very good primary care sports medicine physicians. They also specialize in concussion assessments, and they do concussion assessments in our Billiken athletes as well. And then Lauren just joined us from Chicago, and she's very experienced in sports medicine as well, and she'd be happy to see you as well. We're not just interested in seeing patients in clinic. We are part of the university, we're faculty, and so we deal with residents. We're involved in research, so even if it's a question of research or getting involved with SLU, we're happy to talk about that as well. If you do need to get a hold of us, we do have a website, SLUCare.edu at SportsMed. You can find a lot of information about the orthopedic surgery program at SLU and our residents, as well as the surgeons. All our physical therapy rehab protocols are online, so you can take a look at those if you have an injury and you're interested in the rehab. And then there's a central number that you can call as well. And between the 5 of us, we're actually in a lot of different locations, so you'll be able to reach us wherever we are. Dr. Carr and I and Lauren, we all have clinics, and we also operate here out of St. Mary's Hospital. But we also have clinics and operate out of SLU Hospital South Campus, and we're all at Cardinal Glennon as well, and I do surgeries at Cardinal Glennon as well. And we take care of most of the SLU athletes and students at the Student Health Center as well. Thank you.
All right, thank you, Dr. Kim. Who knew there were so many ways to injure yourself, but luckily that's why we have you and your team, right? Mm-hmm. So we're going to take some questions from our viewers. And we were talking a little bit about how long to start playing again. Mm-hmm. So we have a question about ACL surgery. So I recently had ACL surgery, and I want to get back into sports. How long do you think it will take me to get back into soccer?
Mm-hmm. So returning to play after an ACL surgery is can be considered a controversial topic. It does vary depending on the type of surgery and the surgeon doing the surgery. On average, people will return back to sports anywhere between 6 and 9 months after surgery. 6 months is probably the earliest that I would like to hear somebody go back to sports. In my practice, I like to push it to about 9 months, but I won't be disappointed, and I try to remind the patient not to be disappointed if it takes a full 12 months to return back to sports. A common thing that I like to tell my patients is it took Derek Rose a full year to come back after his ACL surgery, and that's not late, it's completely appropriate. And so it's not always the best thing to push your return to sports too early. So I would say on average 6 to 9 months, 12 months is totally reasonable.
Is an ACL tear ever treated without surgery?
ACL tears, unfortunately, don't heal on their own. But as you can imagine, they're not life-threatening injuries. So you can live without an ACL. The trouble you'll have without an ACL is when you do turning and pivoting motions. And without an ACL, you'll have the sense of your knee giving out. So if you don't do a lot of that, and if you don't have a lot of instability, technically you don't need an ACL surgery to have it replaced. Having said that, most people who get ACL tears are active and athletes who usually want to get back to those things. So the majority of the time, if you have an ACL tear, patients will end up getting it reconstructed.
This is from a viewer with a son who's a 14-year-old promising pitcher. He plays on select teams in the spring, summer, and fall, and will be trying out for the high school team next year. How much training is too much training?
Well, there's actually a lot of research on pitching in the pediatric and adolescent population, and even in college players. The danger being that if you do too much and you end up with an injury, you miss out on your chance of playing for more higher level teams. There are a lot of numbers out there and a lot of newer research coming out every day in terms of how much is too much. Generally speaking, and what is fairly common knowledge amongst baseball enthusiasts is that perhaps 80 to 100 pitches, limiting to 80 to 100 pitches is max. Try to limit the number of teams you play on. So studies show that if you play for more than one team, you're more prone to injuring your elbow. If you play more than, these are also studies, if you play more than 8 months a year, you're also at increased risk of injuring your elbow or shoulder. And so, what people will recommend is trying to incorporate a rest period throughout the year from pitching. So there are a lot of studies out there, there are a lot of numbers and recommendations in terms of limits to how much you should pitch and for how long throughout the year you should pitch. So playing for more than one team is a risk factor, more than 80 pitches a game is a risk factor, playing more than 8 months a year is a risk factor, and there are a lot of more other numbers that we can talk about, but I'll leave it at that.
So I have a rotator cuff tear. Will it ever heal without surgery? And what is the purpose of the injection if it doesn't help the tear heal?
So the rotator cuff tear, we think, does not heal. Having said that, as we were saying before, even with the rotator cuff tear, you can still regain your motion and strength just fine. So what the injection actually does is it's typically a steroid injection, and what it typically does, it helps settle down inflammation and pain, so that you can accomplish, or so you can go through your physical therapy and accomplish your goals of motion and strength. So the injection is not healing your tendon in any way, it's helping you feel better so you can do your physical therapy.
So let's talk a little bit about shoulder arthritis. So we have a viewer who has shoulder arthritis and it hurts, and she's told that she needs a shoulder replacement. Are there any options other than surgery for that?
So shoulder arthritis and shoulder replacements, of course, is always the last option, and there are a whole lot of non-surgical things that we try to do before having to resort to a shoulder replacement. And really what they try to accomplish is try to help reduce your pain, because we can't regrow cartilage. So some of the things that we do non-operatively are physical therapy. So people with shoulder arthritis get very stiff. So we try to stretch out the capsule, and sometimes that helps them feel a lot better. We do injections very often of the shoulder joint, again, help settle down inflammation. And sometimes that helps a lot, enough that patients are happy and don't need a shoulder replacement anymore. It's controversial, but every now and then we do shoulder arthroscopy for shoulder arthritis. If we feel like, especially if we feel like the pain is not necessarily from the arthritis, but something else, such as the biceps tendon, or maybe the rotator cuff, or something like that, there are some surgeons that will address those things with arthroscopy to try to help with the pain. Of course, having the understanding that the arthritis is not changing and that the arthritis pain may still be there. And then there are the usual things like anti-inflammatory medications and so on.
I am considering knee surgery to have my meniscus partially removed. How long will it take me to recover?
After any simple knee arthroscopy, what normally happens is, this is normal for everybody, is your quadriceps, they deactivate and they kind of shut down and atrophy a little bit. And that happens with the simplest knee arthroscopy. And so if you have a simple partial meniscectomy, a simple knee scope, 30-minute procedure, it'll still take a good 2 or 3 months for your quadriceps to come back. And so I usually tell patients it'll wait at least 8 weeks before you start feeling like yourself again. And if you're an athlete, I usually clear them by 2 or 3 months to return back to sports.
So let's talk a little bit about improvement from a surgery. How much improvement can a person expect from surgery? I know it's a pretty general question.
Mm-hmm. Well, of course that'll depend on the type of surgery that we do. Generally speaking, we do surgery because we think we can make a patient better than they are when they first come in. The results of sports surgeries are fairly good. You would have to ask me a specific sport or a specific injury. I can tell you some good numbers. But generally speaking, if we're doing a sports medicine surgery, whether that's an ACL, a labral bone gut repair, a cartilage repair, something like that, the ultimate goal is to get you back into sports. And we're fairly good at that.
So I know we talked a little bit about marathon training and training for things like that from running. So we have someone who's training for their first marathon this fall, and they've heard a lot about stress fractures. What are they, and what can they do to prevent them?
To put it simply, stress fractures happen anytime we walk or anytime we run. We put stress through our bones, and there are what we think little micro injuries to the bone. That's a normal process. And when we rest, those micro injuries have a chance to heal. So if you're putting a lot of miles and a lot of pounding through your bones, and they have those micro injuries, and you're not giving a chance for those bones to heal, and you keep training on them, eventually they don't heal. They start off with what we like to call a stress reaction, where it starts to hurt, and then that could eventually progress what we think is a stress fracture. So the most important thing you can do is, again, incorporate rest days if you're having pain, to rest the bones, to give it a chance to heal. The other thing is to optimize your nutrition. Like I said, in our athletes, I make sure that their nutritional levels are optimal, because that gives a chance for those bones to heal best as well. And another thing I always check is smoking. Smoking can actually very much inhibit your body's ability to heal. And so if you do smoke, it's a very good idea to quit.
Yes, quit smoking. All right, this is our last question. So this is pretty specific, so hopefully we can get some good answers from you. So I tore my shoulder and had a Bankart lesion more than 10 years ago in a skiing accident. I had it repaired, but then retore it. That time was a slap tear. A few years later, while lifting weights, I underwent a second surgery, but tore it again within the year despite following all of the doctor's orders. While I'm not in constant pain, I'm not able to do heavy lifting or do some of the activities I used to enjoy. Not interested in doing surgery a third time unless there's some guarantee that the result will be different this time. Any suggestions for how I can improve function?
Well, ultimately I'd like to take a look at the shoulder and maybe some imaging to see what exactly is going on. Labral repairs are very common in young patients. They typically happen after a shoulder dislocation. And usually after a labral repair, the shoulder feels quite stable. Slap repairs are a little bit of a different animal. Generally speaking, slap repairs we like to do in younger patients. probably around 35 to 40 or younger. Any patients who tend to be older than that don't do quite well with slap repairs, meaning they have residual pain and dysfunction. And so in older patients with slap tears that are bothering them and that we can't get better with conservative treatments, what we often do is we actually just cut the biceps tendon, and a slap tear is where the biceps tendon pulls off the anchor a little bit. We actually cut the biceps tendon and reattach it to a lower location, and then we leave the anchor alone. And that actually has fairly good results. So if it's a slap repair that's bothering him, and he's over the age of, let's say, 35 or 40 years old, it's a reasonable option to have what we call a biceps tenodesis, because again, slap repairs are known to bother people. I hope that answers the question.
Absolutely. All right, thank you so much, Dr. Kim. If you asked any questions and we weren't able to get to them, please feel free to give Dr. Kim's practice a call. If you want more information, also the number is right here, so it's 314-256-3850. Thank you all so much for joining us today.